So now we already discussed in detail about the various steroids which are produced. Of course, we discussed about catecholamine, which are there from the medulla, cortisol, the glucocorticoid, DHEA is the sex steroid, and aldosterone, which is basically the mineralocorticoid. Out of all these, which one is most important, Dr. Nimisha? Cortisol. So if you have a child who has no cortisol, who will die first? So you should understand that way, na? So if you have a deficiency of cortisol, will they die first? Deficiency of aldosterone, who will die first? Or DHEAs? So DHEAs deficiency, nothing is going to happen. Cortisol versus aldosterone?
Cortisol deficiency.
Aldo, salt wasting will be in aldo, na? So that is much more different. But if you have no cortisol, no epinephrine, no aldosterone, will you be born or not? Will the child be born or not?
It will be born because mother.
Somebody has got no adrenals till they are born. Somebody who has got no pituitary, anencephaly, they are born because mother is taking care of everything. Which steroid, which I have not mentioned here, if it's not there, the baby will not be born. The pregnancy will not be sustained. So which hormone is sustaining pregnancy, which is in favor of gestation? The name itself will tell you the clue. So which is the hormone which sustains the gestation?
Progesterone.
Progesterone. So the most important product, I'm not talking about adrenal, the most important steroidogenic product is progesterone. If there is no progesterone, the pregnancy there'll be abortion there. So this is important, and that's why people used to say that if there is a problem in the side chain cleavage or that sort of a region, you will not have any progesterone, so this will not survive. Although minor forms have now been identified. So that's why progesterone is the most important scenario from that regards. Yep. We will be talking in more detail about adrenal steroidogenesis when we talk about CAH in detail, but a bit about cellular processing you need to understand. That within the cells, you've got the endoplasmic reticulum and the mitochondria, and within them there is a shuttle which goes on in terms of, it's like two factories working and they will have back and forth. So cholesterol in the cell has to be pushed into the mitochondria, and the protein which is responsible for that is the steroidogenic acute reactionary protein or STAR protein. Now, without STAR also, you will have certain amount of cholesterol which goes up, but STAR really speeds up. And within the mitochondria, you have got the multiple enzymes, the 11 hydroxylase, the adenoreductase enzyme. And then from this side, you have got the 3-beta HSD, 21 hydroxylase, 17 hydroxylase. So there's a shuttle which is there, which is working from that regards, and which regulates the overall synthesis. And finally, they have to go for 11 beta hydroxylase to produce cortisol from that perspective. Now, what all hormones are going to control your STAR?
STAR is controlled by ACTH.
ACTH. Everywhere?
In adrenals.
Okay. Zona glomerulosa also ACTH controls STAR?
Yes.
So if you have ACTH deficiency, you don't have any aldosterone.
No, it will have because it is dependent on the renal pathway actually.
So which other hormone controls STAR? Angiotensin 2.
Angiotensin.
And what about testis? LH. Ovaries, again LH. So basically, it's the same STAR which is there everywhere. It's not that you have got only adrenal specific STAR, it's there everywhere else, which is there in that regard. So ACTH, of course, is a major regulator which happens from that regards. And 11B2 or aldosterone synthase will produce aldosterone. So there's a difference between mitochondria and the endoplasmic reticulum, which you need to remember. Now, DHEAs is predominantly produced via the endoplasmic reticulum, while the other two steroids are produced via the mitochondria. We'll talk a lot about which enzyme decides the pathway of the destiny of steroidogenesis. So if you have got no 17 hydroxylase, you will produce aldosterone. Zona glomerulosa. 17 hydroxylase, yes. Lyase, no. You will produce cortisol. Zona fasciculata. Both hydroxylase and lyase, DHEAs, that is zona reticularis. So this is how it will work. Now cholesterol is largely there in the body, which is there from the LDL receptor. So most of the cholesterol is not being produced by the cell. It basically comes via the LDL receptor. And from there, the DHC7 is going to produce cholesterol, and this is going to come up via the LDL receptor. Now, HMG-CoA, of course, is going to produce that. So use of statins, will it cause adrenal insufficiency? You are inhibiting HMG-CoA? Or why will it not cause? Because statin is theoretically decreasing cholesterol, and your cholesterol is essential for the steroid pathway. Because this LDL pathway is also there, and there is also a HDL pathway. There is also a HMG-CoA independent pathway. So and you need zeros. Even with the statin, you will not have zero. You will have some cholesterol which is being produced. So this is important on that regards. And this cholesterol has to be immediately converted into cholesterol sulfate. If you have a problem in conversion of cholesterol sulfate, you will have a problem of Alapan. If you have a homozygous, it will be Wolman syndrome. Heterozygous will behave like a non-alcoholic fatty liver disease. So esterase and lipase. So lipase defect is what is known as a Wolman syndrome. HDL, we already discussed, is to be transferred inside using CLA1, which is regulated via two antagonistic compounds, NRA51 and DAX1, which is going to inhibit that. So this is how these two major genes are going to regulate your steroidogenic pathway from that perspective. Now, we already talked about that cholesterol transfer happens via the star, and this cholesterol transfer is going to happen faster if somebody has got the steroidogenic acute protein. So if you have star deficiency, your steroidogenic pathway will become less, but you will not become deficient. You will have enough. So when we talk about CAH, we say that if you have more than 5% activity, you are fine. You don't have any problem. Now with star, if I tell you that if suppose star is defective, you will still be producing 20%, 15 to 20% steroidogenesis is there. So why would a person with star have adrenal insufficiency then? You've got 15 to 20%. So what is going to happen? If you have no star, you will produce more ACTH. More ACTH means more cholesterol, and that cholesterol is going to there where it's not going inside, it's in the
cytoplasm, then it will degrade the adrenal.
So it will kill the cells. So that is the second hit model. So star defect is a classical example of a second hit model. So here what you are seeing is there, cholesterol is going to get accumulated, and this is going to destroy the thing. Second hit model is typical of neurophysin defect, many a GHD splicing defect, where all you can also have a second hit model, which is there from that regards. I am not going to talk much about this pathway today because we have got a full 2 sessions on CAH. So this is something which I'm not going to talk about. Only thing to remember here is that side chain cleavage and star are going to block the entire pathway. So you've got a low level of all metabolites. 3-beta-HSD would mean that you will have no production of cortisol and aldosterone, and lot of this DHEAS which is being produced. 21-hydroxyl will of course mean that you will not have any production of the cortisol and aldosterone, and a lot of androgens which is going to come up. This is going to be covered later on. Now, most of the hormone that I'm talking about are steroids hormone with the exception of catecholamine. And of course, when you talk about steroid hormone, they will have a problem in terms of passage within the blood. So what is the hallmark of steroid hormones, Dr. Sandeep, in terms of their features?
Just steroid hormone, they crosses the cell membrane easily, sir.
Yes. So before that, before reaching the target organ, what about the blood?
They need to be bound to CBG, sir.
So because they cannot really pass, they are basically a hydrophilic group of hormones. So like cortisol, they are fat soluble but water insoluble. So within the blood, they need to be bound to a binding globulin, which you have very clearly talked about is the cortisol binding globulin. Now, what is the role of this CBG?
The CBG binds and bring the steroid to the target.
So it is going to bring it to the, so it's also targeting it. What else does it do? Compared to peptide hormones, what is the half-life of steroid hormones? Is it less or more?
More.
Why?
Because of CBG, sir.
Yes. So if you look at insulin, if you look at AVP, if you look at GnRH, within a few minutes, they are gone. While here, because this binding protein is not just binding, it's protecting also. So it is protecting it basically from the enzyme activity, and therefore they have a more longer half-life and a more stable profile from that perspective. Now, as you said, this cortisol will then be taken by the binding protein to the target site, and there you will have a very, very important activity which will determine its action. So how do you ensure that some tissues, so cortisol level are the same everywhere in the body? How is it determined that in this region cortisol will act, here cortisol will not act? What determines the site specific effects of cortisol?
It is the presence of enzyme like 11 beta HSD2, whether it is
Okay,
present
so
or
one you have talked about this CBG, which is going to
Ah,
take,
okay.
okay, so I want this cortisol to work at immune system. So I'm going to take it there where the thymus is working. Then second, you talked about the enzyme metabolic activity. So how does metabolic activity regulate cortisol effect? And in which cells?
it is 11 beta HSD2 activities are more in the kidney tubules, in sweat glands and colons.
So you have got two 11 beta HSD.
One is 11 beta HSD1,
What does it do?
which activates the cortisol,
Yes.
cortisol to cortisol.
Yeah.
Another is 11 beta HSD2, which deactivates. But
Okay.
11 beta HSD also have concentration dependent change.
So basically what you want is that those tissues where cortisol has to act, you want to augment its effect. And those tissue where you don't want cortisol to act, you have to suppress it. So 11 beta HSD2 is largely a inactivating enzyme and 11 beta HSD1 is a activating enzyme. So Dr. Vibha, what do you think will be the K max as to the what concentration? Will 11 beta HSD work at lower concentration, or 11 beta HSD2 will work at lower concentration?
11 beta HSD. So for the cortisol?
Yeah, so 11 beta HSD1 is activator and 2 is inactivator. So suppose cortisol level is 500, both is working, but in some tissue the cortisol level is 50. Which of these do you think will be will be working still?
So if the cortisol level is low, then 11 beta HSD1 will be more working because it has to be converted to the activating.
Yes, but you also don't want that to affect the mineralocorticoid receptor. So if you basically think about it, why do you have 11 beta HSD2? It's a shield. So 11 beta HSD2 will be a more active one at a lower level. Also, you want 0. So even if one molecule of cortisol goes in, you may have activity on the receptor.
So, but at low level, then
it can still, so
okay, it has to be inactivated at low level.
Yes. Why? Because if you now compare the concentration of cortisol to
Yes.
aldosterone,
It is much higher than
so if
the
you talk
aldosterone.
about its cortisol is nanomoles,
Yes.
aldosterone is picomoles. So there are 1,000 times more cortisol as compared to aldosterone.
Yes.
So if suppose let's say, okay, 10 times less cortisol is there, but still that 10 time will be 100 times more than aldosterone. So 11 beta HSD2 will be like a sentinel who has to look at every molecule and kill the molecule. So you are not allowing that. While if the levels are less, body will say, okay, maybe the activity is less, you can't activate that much, that is there. The second point which Alapan talked about was if the levels are very high, then your 11 beta HSD1 will act in a different fashion. It is then going to decrease the activity. It's going to convert it back to cortisone from that perspective. So, Dr. Sandeep, what are the response to a very high level of cortisol by the body? If suppose you are exposed to a supraphysiological level of cortisol or hydrocortisone, what will happen to the body?
Sir,
What
first of all-
mechanisms it will develop?
So first of all, the CBG has a limited capacity. So
Yes.
After 700, it will start passing in the urine.
Good. So it will be lost in the urine. Number two.
Secondly, sir, 11 beta hydroxy dehydrogenase 2 will be activated.
2 is only there in some tissues. 1 is there in cortisol responsive tissue. So what I was saying is that if the level is too high, 1 is trying to inactivate it. So that is how you are shielding. Third, what will happen to the receptor?
Saturation of the receptors.
Receptor will get down-regulated, desensitized. Of course, your CRF will go down, your ACTH will go down, that's different.
Yes, sir.
But what body is trying to do is that if your level is 1000 continuously, it is going to make mechanism by which this high level is not going to adversely affect the body. Now, in this setting, if suppose you have a patient with Cushing syndrome, and Dr. Nimisha, who has been exposed to very high level of cortisol and a surgery is done, his level now is 300. What do you think will be the problem in this case? His levels are normal now. It was 1000, which was double the normal level, and now the level is 300. But he is complaining to you that I have weakness, lethargy, blood pressure is low. What do you think is happening now? So what was his body adapted to?
High level.
Very high level. So now all these problems that you did, that your receptor was desensitized, your 11 beta HSD was inactivating, this is now for that level, he will start feeling a adrenal insufficiency like picture. As we often see that somebody whose sugars are 500, you bring them down to 150, they start feeling hypoglycemic because body is adjusted to that. So this is important thing to remember, that after Cushing's treatment, they may still feel symptomatically weak even if their cortisol levels are normal. So this is a mechanism to understand from that perspective. Now, as discussed, cortisol can freely cross the membrane and is going to act on the intracellular receptor, which we'll talk a bit more subsequently from that regards. And as discussed, the 11 beta hydroxysteroid dehydrogenase is going to decide whether it's active or an inactive form. If you think of it, it is similar to many other hormones. So what all hormones are prohormones in the body, which have an enzyme there which will decide their fate of action.
Thyroid hormones.
So T4. T4 is not going to do any work. If you need work, you will convert it into T3, otherwise reverse T3. Second,
Vitamin D.
that's a different mechanism altogether. Yes, but something else at the tissue level. Very important. And it is actually a very interesting phenomena. It will have a effect feminizing or a virilizing effect. So testosterone is also essentially a prohormone. Either it is aromatized to estrogen or DHT. So this is the same mechanism by which your enzyme activity is regulating the expression there from that perspective. So now we already discussed briefly that cortisol is bound to the cortisol binding globulin, which is not just a binder, it is also something which is going to target that cortisol to different places and protect the cortisol from being degraded. So there are other ones which also bind cortisol, including albumin and alpha-1 glycoprotein, but major one is CBG, 90% of this. Now CBG levels are increased, of course, in many other conditions. So binding globulins increase in pregnancy and with the use of estrogen progesterone. So what does it mean in terms of the hydrocortisone requirement in somebody who is, let's say, adrenal insufficiency becomes pregnant? Do you think there will be a change in hydrocortisone requirement?
Yes, sir.
Because
Free cortisol levels will decrease.
yes, so because if suppose somebody has a normal ACTH, they will be able to manage it. But here it will be bound. So roughly 30% increase will be there in terms of cortisol requirement, as happens with thyroxine requirement also goes up from that perspective. The other important thing to remember is that oral contraceptives. If you have somebody who has got subtle adrenal insufficiency, and in that scenario you give estrogen progesterone, can there be a problem?
Yes, sir.
You may precipitate deficiency. So that is why it's very, very important in individuals who have premature ovarian insufficiency. How many of POI patients will have cortisol deficiency? Is it common, uncommon, rare? It's a very important association, 20 to 30%. So if you are diagnosing somebody as an autoimmune APS2, APS2 is basically, adrenal is a very, very important scenario. So you should definitely do a cortisol level along with thyroid and other aspects to exclude that. Because if you have subtle deficiency, it may cause more problems once you give estrogen therapy from that regards. The level will decrease with liver disease and nephrotic syndrome. So many patients may be referred to you as low cortisol. So gastro people, they will do a sodium which is low and then cortisol is low. But then it's very difficult to identify because this cortisol may be because of low CBG level because of a liver disease. Now serum levels are pretty stable. Dexamethasone and prednisolone do not bind to CBG. This is something you need to remember. That's why they have a higher potency. The levels are saturable. So as Dr. Sandeep was talking about, CBG will be able to hold up to around 700 nanomoles per liter. If you have a very high level of cortisol, it is going to spill over in urine. So when you are treating somebody for acute adrenal insufficiency, it's always better to give a continuous IV infusion rather than the repeated boluses. That is something which has to be avoided from that perspective. So Dr. Alapan, 16-year-old girl with obesity and hirsutism with menstrual irregularity, buffalo hump, overnight suppression is 150. Normal value is less than 50. So this is Cushing's.
No, we have to ask for the drug history in this case.
So what would be, okay, so drug history, ACTH is here is 10. Advise MRI.
No, the child is having menstrual irregularities. So if she's
So you have
taking any
to
kind of
ask
drugs,
for
we
whether
have
there is a OC pills which are being given. Which test will you prefer if somebody is on OC pills?
So we can go for the free levels like in urine or salivary levels. We can
Okay,
check for
sure.
that.
So in this case, UFC will be a better form. Urinary free cortisol will be important. Dr. Vibha, 12-year-old boy with liver disease. Sodium is 128. There's hyponatremia, hypokalemia. Urinary sodium is low. So this child doesn't have a high urinary sodium. Fluid overload is there clinically. Cortisol is 50. You have been asked by the gastro team that this is somebody who has adrenal insufficiency. Please start steroids.
First of all, it is a liver disease. In case of low sodium and low potassium, two things should be ruled out, like cortisol and thyroxine and the other things. And in case of this, albumin have to be ruled out. What
Yes.
is the level of albumin?
So if you think of cortisol deficiency as the primary cause, the urinary sodium should be high because it's like either SIDH like state. So urine sodium should be at least above
20.
25 minimum. So this is low. So that goes again. This is more going in favor of a overload, effective hypovolemia. So in this case, probably you should be looking at, now this is very difficult. Which test will then help you out? Because urine free cortisol is good for excess but not for deficiency. So some people talk about salivary ones, but then the cutoffs are not very well established. So this is a very challenging condition. But do not start steroids in this scenario. This is not because of that. If your albumin is very low, like in this case, albumin is 1.5. So this is not a, this thing in free cortisol is not usually available. You can use a salivary cortisol in that regard.
Not available, you can wait still for this case.
Yes, so this is not fitting into. Suppose he had pigmentation. Other thing you can think of is what is the ACTH level. Whether there is a high urinary sodium, which is not fitting, then you can think of it. But otherwise, hold on from that regard.
So, okay, if we are not able to just Alapan asked, if we are not able to get the free salivary cortisol,
Yeah.
so in this case, can we go for the ACTH level of?
We should get a ACTH at least just to document. If the ACTH is very, very low, see, this could be central. Mota mota, the only thing which is there, it could be central. So in that case, ACTH should be very low, and then you're thinking of a, because many of the gastro people will refer to us with multiple pituitary hormone deficiency. But that presentation, this is a liver disease, known CLD. Somebody whose albumin is 1.5. So that's why we are a bit this thing. But here, getting a ACTH, getting a thyroid, basic workup will help you out also from that regards. But don't treat this scenario because he is already not fitting into cortisol deficient. Now, local metabolism is extremely important. We've discussed that cortisol is converted to cortisone via two enzymes, 11-beta-HSD1, which is going to activate the cortisone to cortisol. It's there in the target tissue, and 11-beta-HSD2, which is there predominantly in the mineralocorticoid responsive tissue, predominantly in the kidneys, to convert cortisol to cortisol. It's there in the kidney, the colon, and the sweat gland. Growth hormone is going to activate the 11-beta-HSD2. So if somebody is on adrenal insufficiency and you start growth hormone, you may precipitate an adrenal crisis. Thyroxine also has an effect out there. So before, and this is something which we always talk about, if you have a child who has central hypothyroidism or GHD, think of excluding cortisol deficiency before you start treatment because you may precipitate the adrenal insufficiency in that regard. Now, cortisol, of course, is something which is going to act via the intracytoplasmic receptor. So it is basically the receptors are there in the cytoplasm and not in the nuclei. So cortisol will cross, it will bind to the dimerized receptor, dissociate it from the heat shock protein, and then it is going to take it towards the nucleus and acts on the hormone response element and act via a transcription process. So it's basically a transcriptor factor, associate production of protein. It also is going to act via the membrane receptor. So we always say that genomic pathway is via the steroid hormone, Membrane receptor are via peptide, but there are exceptions. Last time I talked about that growth hormone is a peptide hormone, but ultimately it is controlling your through JAK-STAT, SRE, STAT-related elements. Here, cortisol also has a rapid effect, which is there. So, without cortisol, the co-suppressor is going to suppress the expression of genes. When you have a cortisol production, these co-suppressors will go off and co-activators will come in. Therefore, this activity will start happening and the activation happen. Dr. Sandhi, why do you think there is a pressure activity happening in the normal scenario? So in a normal individual, you want cortisol action to be there or not?
It should be
Minimal,
minimal.
as and when needed. So, like if you want to have, let's say, a default button for the AC, you want it to be default on or default off?
Default off.
Default off, and you have to on it. So that is why you have a repression happening. On the other hand, if you have, let's say, something like a refrigerator, you will keep it default on so that when you don't need it, then only you will switch it off. So there is a repression happening. One other thing that repression helps is, suppose the normal activity is 1. You are keeping it at 0.1. Now, that activation makes it 10 times. So the difference here is 100 times. So in hormones, wherein you want to have a lot of difference in terms of response, you will keep a repression activity. So removal of repression itself will cause rise, and then you have a rise there. So this is how the cortisol effect is manifested from that perspective. In certain scenarios, the cortisol can also have an inhibitory effect. So where do you think cortisol is going to inhibit the gene expression? So it's going to stimulate gene expression, but it's also going to inhibit gene expression.
Growth it will affect. Sir.
Growth, then a lot of immune reactions, a lot of production of other compounds, it will have an effect. Vitamin D, 1 alpha hydroxylase is going to inhibit. That's why we are using it in hypercalcemia.
Yes.
So it's going to affect both increase and decrease production, which is going to be there. This is the trans repression which is happening. So now to summarize the hypothalamic pituitary regulation, cortisol is going to suppress ACTH. It's going to suppress AVP. It's also going to suppress the CRF. So if you have initial cortisol deficiency, the hypothalamus goes off. Then the pituitary goes off. When both hypothalamus and pituitary go off, the adrenal will shrink. So if you have a long-standing cortisol exposure, you will have complete knockdown of the HPA axis and you would need long-term time for this to recover. IL-1, IL-6 stress, hypovolemia, I already discussed, increases ACTH in that regards. Now, before we conclude, we'll just talk a bit about the effects of cortisol. So it also has the effect on growth. It is suppressing growth, on bone mineralization, on metabolism, immunity, skin, and the HPA axis, of course, are affected. What about growth? So we all know that cortisol is bad for growth. It is going to suppress. So what are the effects of cortisol excess on growth?
It will decrease growth
So
hormone.
yes, so cortisol is going to decrease the growth hormone production. It is going to reduce the growth hormone action also. So it's going to cause everything, growth hormone action and even IGF action. So every part of the GH, IGF and axis is going to be affected by the excess of cortisol. It, of course, will have also a bad effect on bones. So what are the mechanisms of bad effects on bone, Alaphan, of cortisol? And why you have glucocorticoid-induced osteoporosis?
So it actually decreases the osteoblastic activity by the DMP2 pathway and RANX pathway. Increases the osteoclastic activity by Rankel pathway. It increases the loss of calcium via kidneys. So the calcium absorption is less. It inhibits the 1 alpha hydroxylase. So the conversion of to vitamin D is less. And
so
also
cortisol is
direct action
affecting
on the
everything. So as you said nicely, there is an effect on the osteoblast, so less bone formation. You have got more bone resorption because of the effect on the osteoclast, the rank ligand OPG pathway. The absorption of calcium and phosphorus, both of them will be affected, predominantly the calcium, and vitamin D effect, of course, is there. So it will have a bad effect on bone. We also know that cortisol is basically an anabolic hormone. So it's going to do everything which is opposite. It's a catabolic hormone. It's going to do everything which is opposite to the insulin. So if you have got more cortisol, what's going to happen? You will have more glucose coming into the system. You will have also effects in terms of loss of protein, because protein is now being burnt to produce your cortisol. Body is in a starvation mode. It will say, okay, I need to produce glucose. I'll kill my muscle mass. So it is going to go off. You will of course have abnormal fat distribution because of the effect of the lipid pathway, and there will be multiple other effects. The cortisol metabolism basically is via the P450 enzyme, the CYP354 into glucuronide, and then it is excreted in the urine. There are various mechanisms by which you can do urinary studies to look at the steroid profile, and this will give you the real picture as far as the cortisol level is concerned. Drugs like anti-epileptic drugs and anti-tubercular drugs can increase the inactivation of cortisol. So the classic presentation which I have seen in this scenario is a typical middle-aged woman who is not doing well, who is looking sick, diagnosed as tuberculosis, started on anti-tubercular drugs, comes to us with shock. What do you think is happening here? She had amenorrhea for the last 10-15 years, which was neglected.
Yes, sir. Adrenal insufficiency, sir.
So what does ATT basically mean in our setting usually? If somebody started on ATT, what does it mean?
Rifampicin will increase the cortisol requirements, sir.
We agree that rifampicin is increasing cortisol requirement precipitates, but generally, if somebody is started on ATT, if a child is started on ATT, what does it mean?
There must be tuberculosis somewhere in the body.
That he might have been sick. Anybody who is sick, whom we can't explain, ATT started.
Sir.
So if you see a child who has, we've seen so many hormonal conditions in which is ATT started. And similarly, somebody who's not doing well, people will give a trial of ATT.
Yes,
So this basically is something which is very common and that can trigger that. Anti-epileptic drug interaction also we have seen in the setting of a macroadenoma which can cause. On the other hand, drugs like voriconazole, clarithromycin, ritonavir may actually inhibit the metabolism. So they may cause Cushingoid-like effect even at a physiological doses from that perspective. So basically, I think we'll close it here and then we'll continue with the second session. So this is basically being converted. There are various enzymes from which you have the conversion there. You've got 11 beta HSG2, which produces dihydrocortisol and corticosterone, 3 alpha HSD, and finally you have got the cortisol and cortisone. So cortisol is a derivative of cortisol, cortisone of the derivative of cortisone. The ratio of the two will tell you the diagnosis of 11 beta HSD2. If you have 11 beta HSD2 defect, you will have which one will be more? Increased.
Cortisol.
So you will have much more cortisol as compared to cortisone. So urinary ratios are important for what is known as the apparent mineralocorticoid excess. So 12-year-old boy with GHD, on growth hormone now complains of lethargy and weakness and hypotension, hyponatremia. What do you think is happening?
So this child has having lethargy and weakness with low BP and hyponatremia, suggesting a
And on growth hormone, he was fine, he was okay. But with growth hormone, he became sick.
So he was started growth hormone
Recently, yeah.
So before we start with the growth hormone, we should level for the other deficiencies like cortisol deficiency.
Yes.